Assalamualaikum and salam sejahtera. I'm Dr. Zahril Akmal bin Usaili, some emergency physician in Hospital Seri Manjung. Okay, we are going to proceed with the next topic, which is abdominal trauma. Okay, basically, when we talk about abdominal trauma, it begins during the circulation assessment from your ABCD. Okay, we should consider potential cause of abdominal injury if any penetrating torso between the nipple and perineum. The unrecognized abdominal trauma continues to be the cause of preventable death. Actually, there is significant blood loss can be present in the abdominal cavity, even though without a damage in the external appearance. Okay, any injury to the torso from the direct blow, deceleration, blast, or penetrating injury must be considered to have intra-abdominal injury until proven otherwise. Okay, basically our objective of this presentation is we want to identify the anatomical region of the abdomen. We want to recognize the pattern, the patient who is at risk based on the mechanism of injury. The one we want to identify patient for urgent surgical intervention. Then we want to know how to use the appropriate diagnostic procedure. Then the last one, you want to describe the acute management of abdominal and pelvic injury. Okay, first we want to talk a bit about the anatomical of the abdomen. There is external abdomen, internal abdomen. Okay, I think we just go through the anatomical. There is lower abdomen, anterior abdomen, the one we call the flank, and also the posterior abdomen side. Okay, the interior abdomen, we have peritoneal cavity, is the upper thoracic abdominal component, diaphragm, liver, spleen, stomach, and transverse colon. Retroperitoneal space. Okay, retroperitoneal space is a very important because we cannot see this retroperitoneal space from our EFAS finding. Okay, it's abdominal aorta, inferior vena cava, most of duodenum, pancreas, kidney, and ureter. Posterior aspect of the ascending and descending colon, retroperitoneal compartment of the pelvic cavity. Okay, the last one we have a pelvic cavity. Okay, for the assessment of abdominal injury, okay, I think the most important things is history as a important part of the assessment. By knowing the mechanism of injury, we can predict the type of injury. Basically, there is two type of intra-abdominal injury. First is a blunt abdominal trauma. Second is penetrating abdominal trauma, and the last one is a blast injury, which is mix between the blunt and penetrating. Okay, blunt abdominal trauma is a more common than penetrating abdominal trauma. Okay, we go for the blunt abdominal trauma. Actually, BAT or blunt abdominal trauma is a leading cause of morbidity and mortality at all age. Injuries may be not manifest during the initial assessment and the management period. There is always associated injuries, which is divert our attention from potentially life-threatening intra-abdominal pathology. Okay, when we ask the patient, the family members, or the pre-hospital team, what is the mechanism of injury, why we should know the exact mechanism of injury, because based on the mechanism of injury, we can suspect the possible injury occurs to the patient. Okay, the first mechanism of injury is a compression or concussive force. Okay, such as external compression, viscous object, lap belt, spinal column, fees, crushing, which is tears and subcapsular hematoma, deformed hollow organs, and transiently increase intralaminal pressure. Okay, this is the first mechanism, which is compression and concussive force. Okay, the second one is the most common deceleration force, stretching and linear sharing between the feet and free parts of the body. It can cause ruptured supporting structure at junctions such as the hepatic tear, ligamentum teres, and internal injury to the renal artery. Okay, thrombosis and mesenteric tear, which resultant stenic vessels injury. Okay, for the penetrating abdominal trauma, usually the stab wound and the low velocity gunshot wound can cause injury localized to the tract of penetration, tissue damage by lacerating and cutting. Second one, high velocity gunshot wound cause increased lateral damage lateral to the tract of missiles, more likely to involve abdominal vascular structure. Okay, the last one is a blast injury. Okay, like I said before, blast injury is considered the possibility of combined penetrating and blunt mechanism in this patient. Patient close to the source of explosion can incur injuries to the tympanic membrane, lungs, bowel related to blast overpressure. Okay, the potential for overpressure injury should not distract the clinician from identifying and treating blunt and penetrating injuries. Okay, next we go to the third objective, assessment of the patient. Okay, as usual, our assessment, our physical examination is very basic but very important assessment. We use the morning IPPA, our inspection for abrasion, any contusion, laceration, or penetrating wound over the abdominal wall. Okay, we should expect expose the patient so that we can inspect the patient properly. Second, a percussion to look for the area of tenderness, light movement of the peritoneum may elicit sign of peritoneal irritation. Next is a palpation. Okay, we want to look for deep or superficial tenderness, involuntary guarding. Okay, regarding the guarding part is sometimes a bit difficult whether the patient having voluntary or voluntary guarding. But the last one is auscultation for vowel sound. Present or absent of vowel sound does not necessarily correlate with the injury. Okay, next we check for the pelvic stability. Okay, against a normal pelvic spring, we go for gentle palpation for tenderness to detect the pelvic fracture. We need to examine the perineum, gluteal region, and urethra opening. PR examination to assess the anal tone, gross blood, vaginal examination if injury is suspected. Okay, then we need the adjunct to our physical examination. Okay, first and foremost is a extended FAST, EFAST, extended focus assessment sonography in trauma. Second, the this DPL, dynastic peritoneal lavage, I never seen or do it before. The third one is a CT scan. The fourth one is for contrast studies such as ureterography, cystography, IBV, GIT contrast studies. Okay, also for adjunct to physical examination, we're talking about the gastric tube, whether we should insert the gastric tube or not. The function of gastric tube is to decompress stomach before our DPL to reduce the risk of aspiration. Then gastric tube also used to look for presence of the blood. Then we use oral approach if severe facial fracture or vessel skull fracture. Okay, after rest tube is a urinary catheter, again to decompress the bladder before the DPL. To monitor urine output, to look for hematuria, consider suprapubic catheter if inability to void, unstable pelvic fracture, blood at meatus, scrotal hematoma, and perineal ecchymosis. Actually, one thing before we insert the CBD, make sure there is no sign of possible perineal injury. Okay. Usually before this, we look for high riding prostate. Now the latest guideline says a palpation of prostate gland is not reliable sign of urethral injury. So not recommended anymore. If you see the blood from the ureter, there is hematoma over the scrotum, don't try to insert NCBD. Okay, next we go to the investigation. Okay, first we do the chest, the X-ray. Okay, X-ray usually we order anterior posterior chest, pelvic X-ray in the multi-system lung trauma. Sometimes we can order erect chest X-ray in stable patient with penetrating trauma above the umbilicals. Okay, the supine abdominal X-ray in stable patient with penetrated abdominal injury. An alert, awake patient without pelvic pain or tenderness does not require a pelvic radiograph. It's not a it's not a knee-jerk. Patient having skidded, having trauma, MVA, straight away we order the AP and the pelvic X-ray. We should go it by clinical. Okay, second investigation is EFAS. EFAS should be done repeatedly. Okay, when what I mean by repeatedly, when you do your first EFAS, make sure you just your documentation EFAS done by Dr. A at 10:30 a.m. Why we need to document the exact time? Because subsequently, if the first EFAS is negative, we might need to repeat the EFAS and document again the subsequent time. Okay, actually, EFAS is difficult to perform in the patient with obesity, patient having subcutaneous emphysema, and also the previous scar. Okay, usually we scan the precardiac, hepatorenal, splenorenal, and then look for pelvis or POD, and also the lung sliding. Ideally, should be performed at any interval of 30 minutes. Okay, when we compare between the ultrasound or CT scan, there's a lot of advantage and disadvantage of every one of each. But especially IFAS is really operator dependent. You need to do it repeatedly. You need to perform. Then you know how to interpret your IFAS properly. If you're not sure, it's not confident, always ask for second opinion. Okay, I think there's an indication fast and CT scan. Okay, indication for fast is abdominal hemodynamic in blunt abdominal trauma, penetrating abdominal trauma without other indication for immediate laparotomy. Okay, indication for CT scan, normal hemodynamic in blunt or penetrating abdominal trauma, penetrating back or flank trauma without other indication of immediate laparotomy. Okay, now we move to the acute management in the abdominal trauma patient in emergency department. Okay, basically when the patient is hemodynamic unstable, should consider the FAST or DPL as the level 1 recommendation. CT and other contrast studies are contraindicated in unstable patient. You don't delay the emergency laparotomy by doing the DPL if emergency laparotomy is indicated. Basically, if patient unstable, your fast scan is so positive, you need to call surgical immediately. So don't delay the possible of emergency laparotomy. Okay, if fast positive, emergency laparotomy is indicated. If initial fast negative or intermediate, continue with resuscitation, then we repeat again the fast. Okay, how about in hemodynamically stable patient? Usually in hemodynamically stable patient, they will be triaged in our yellow zone. Okay, if our yellow zone very busy, then there is a time for us to miss this patient. Okay, in hemodynamic stable patient, we should consider presence of sign direct abdominal injuries. Okay, expose the patient, looks for any bruises, any hematoma over the abdominal wall. We should consider the absence of pain due to altered sensorium or sensation. If the patient DCS is not full, definitely you cannot assess the abdomen based on the pain or not. Okay, the third one, we should consider presence of severe adjacent regional or multiple trauma. Let's say patient having rib fracture over the lower chest. It might also cause trauma to the liver. Okay, we should consider the presence of hematuria or the blood per rectum. When we insert the CBD, we see got a frank or gross hematuria or not. Sometimes we in hemodynamically stable patient, we send the UFME, LFT, want to look for any hematuria or LFT result derangement. Okay, if any of these are absent and physical examination is reliable, observe and repeat. Okay, we suggest it's not discharged straight away. Even in a blunt abdominal trauma, there's a study suggests we observe until 9 to 12 hours before we decide whether this patient need further admission or discharge from the emergency department. Okay, if the patient remains stable and the repeated physical examination is negative, patient can be discharged. But if you are not sure, just admit the patient for observation. Okay, basically, this is like a flow chart for blunt abdominal trauma. Okay, there's no clinic if there's no clinical indication for laparotomy. Okay, no indication for the diagnosis test, then we observe the patient. Okay, if patient assisto, we pronounce death. Passless, we do immediate thoracotomy. Okay, then we go for abdominal CT, candidate for operative or non-operative. Non-operative, we go to the ICU. Okay, actually, there is a general indication for laparotomy. That means when there is indication for laparotomy, you should call our surgical colleague to come and review the patient because there is possibility for urgent laparotomy. Okay, the first indication is a blunt abdominal trauma with hemodynamic abnormalities and positive fast or clinical evidence of intraperitoneal bleed. When your patient hemodynamically unstable, your fast is positive, there is indication for laparotomy already. Okay, you should call and refer your surgical colleague as fast as possible. Okay, next is a blunt abdominal trauma with positive DPL. Okay, this we. The third one is hypotension with penetrating abdominal trauma. This is a gunshot wound, evisceration. When you get the patient with penetrating abdominal trauma, straight away send for laparotomy. There is no indication for CT abdomen at all. Okay, call your surgical colleague. There is penetrating abdominal trauma. Patient stays stable, but you must send the patient immediately to the OT. Okay, the last one is a blunt or penetrating abdominal trauma with aspiration of gastrointestinal contents, vegetable fiber or bile from the DPL, or aspiration of 10 cc or more of blood in the hemodynamic abdominal patient. I think this is not relevant for us. Okay, other than that, the general indication for laparotomy is a bleeding from the stomach, rectum, and GI tract. Okay, GI tract penetrating trauma, sign of peritoneal irritation, sign of facial penetration, free air, retroperitoneal air, or ruptured hemidiaphragm after the blunt injury, contrast enhanced CT that demonstrate rupture of GI tract, intraperitoneal bladder injury, renal pedicle injury, severe visceral parenchyma injury after blunt or penetrating trauma. Okay, again, emphasize again, we should know the general indication for laparotomy so that we can call our surgical colleague as fast as possible. Okay, this is example pictures of the small bowel injury. Okay, this is a lacerated liver. This is evisceration. Okay, this is evaluation for blunt abdominal trauma in stable patient. Okay, hemodynamically stable, yes. Is there any abdominal tenderness, multiple rib fracture, abdominal wall contusion? If no, admit and then we check again for serial physical examination. Okay, if patient hemodynamic is stable, okay, we don't have unable to do reliable physical examination, so we need to order the CT scan or ultrasound. Okay, if we have our fast scan negative, we can observe and repeat the fast scan again. Okay, if fast scan positive, straight away order CT scan, look for any solid visceral injury or not. Okay, you can go through this algorithm later. Okay, evolution of blunt abdominal trauma for unstable patient. If you have an unstable patient, your ultrasound is a positive straight away laparotomy. If your ultrasound is negative, you continue your resuscitation, evaluate other potential source of shock, then you can repeat again your EFAS, then refer to the surgical team accordingly. Okay, we're done with our abdominal trauma. Okay, now I'm moving to the pelvic trauma. Okay, pelvic trauma is a very important when you it's very important because it's a preventable injury. It's not preventable death from the pelvic trauma if you can recognize it early. Even nowadays, they suggest if a patient unstable in a pre-hospital, you just collar the neck, collar the pelvic. Put the pelvic spring, pelvic binder straight away. Okay, basically, we talk about pelvic fracture and associated injuries. Patient in shock and unstable pelvic have four potential source of blood loss. Okay, fracture bone surface, pelvic venous plexus, pelvic atrial injury, extra pelvic source. Then pelvic should be temporarily stabilized using compression device to decrease the bleeding. Okay, like I said before, we should we suspect pelvic injury, straight away look for pelvic binder. Okay, actually, pelvic injury mortality in patient is all type of pelvic fracture is between 5 to 30%. Mortality rise to approximately 1 in 4. Okay, a range of 10 to 42% in patient with closed pelvic fracture and hypotension. Patient with open pelvic fracture mortality is almost 50%. Okay, there's a pelvic classification. Okay, anterior posterior compression is an open book fracture. It's around 20% of the cases. Then lateral compression. This is the most common pelvic injury, 60 to 70%. You can see the last one is a vertical shear, which is around 15% cases. Okay, pelvic fracture should be suspected and excluded by X-ray in every patient with serious abdominal and lower limb injuries. Okay, local abrasion, bruises, and ecchymosis extending into the labia or scrotum. Okay, your pelvic perforation to elicit pain. Okay, again, no more pelvic spring. Urogenital damage may be present, can develop severe hypovolemic shock if not managed promptly. Okay, this is an example of a pelvic bender. Usually in a lot of KKM setting, we have a SAM spleen. You can make yourself familiar with the SAM spleen. If you don't have the SAM spleen, you can use a hammock like blanket or bed covers. Okay, of course, this is, I'm not sure this is Nina's spleen or not, but there's a external physician for sure by orthopedic team. Okay, this is a pelvic X-ray when we assess when we examine the pelvic X-ray. Make sure you identify all the 5 lines, all the SI joint, all the obturator ring, your then all other lines you should identify. Okay, there's a again ilioperitoneal line. Okay, then we go straight away to the management of the pelvic injury. Same, you go your primary survey, your airway, breathing, circulation. Then make sure you minimize manipulation in the movement, especially when you try to put the pelvic binder. Okay, application of the external pelvic clamp to immobilize the pelvic. Usually, external pelvic clamp put it's just a SAM spleen like that. Okay, this is the flow in our ATLS guideline. Initial management should consult surgical and application of pelvic wrap. Okay, I think we will learn a more detail how to apply the pelvic wrap later. Okay, there is a session. Uh, we will teach you how to apply, especially the SAM spleen. Okay, is there any intraperitoneal blood? There is intraperitoneal blood, straight away laparotomy. If no, pre-peritoneal packing, angiography, hemorrhagic contamination is advised. Okay, this is pelvic fracture and hemorrhagic shock management algorithm lah. Okay, in our TLS guideline book. Okay, basically, I'm finished with the abdominal and pelvic trauma. Okay, as a conclusion, just as a take-home message, always when patient trauma, look for is a hypovolemic shock, hemorrhagic shock until proven otherwise. You try to look of the source of the shock, whether intra-abdominal, extra-abdominal. When then you identify patient which one is a candidate for urgent laparotomy, because you want to activate your trauma team or your surgical colleague to co-manage with us. Okay, with that, I end my presentation. Okay, thank you.